Hi, my name is Chee-Wee, and in this video we'll be exploring the use of the SIN model as a tool for planning our physical examination. Before we start, I'd like to thank a dear colleague of mine, Kirsty McNulty, for sharing her materials with me, which I've used to develop this series of video lectures. The aims of this set of 3 videos are to help us interpret and extract data from our history-taking and subjective examinations to determine the severity, irritability, and nature of the presenting condition. And through our knowledge of the severity, irritability, and nature of a person's clinical problem, we can proceed to plan our physical examination. In this video, we will be focusing on the nature component of SIN and learn how to extract and interpret information from our subjective examination to determine the nature of the patient's condition and to develop a preliminary diagnosis or working hypothesis of the patient's problem. Now that we've determined the severity and irritability of the patient's condition, let's go on to the last component of SIN, nature. A simple way of looking at what nature is essentially what are the structures and mechanisms associated with the patient's condition. This definition is deliberately broad to take into account the physical, psychological, and social aspects of the patient's experience that contributes to the condition. In a way, we're trying to piece together the information from our history taking to paint a multifaceted picture of the patient's condition. There are several categories of information that we can use to help us determine the nature of the condition. The nature of the condition is also our preliminary diagnosis or working hypothesis of what the patient's problem is. This will help us be more targeted in planning out our physical examination in order to obtain evidence to prove or refute our preliminary diagnosis, and also to rethink our working hypothesis of the patient's problem if necessary. In the next series of slides, we'll be looking at some of the information categories for the nature component. This is not an exhaustive list, and it may be necessary sometimes to evaluate more information categories to help us with this analysis. If pain is involved in the condition, we need to determine the type or mechanism of the pain experienced by the patient. So is the pain experienced mechanical nociceptive, inflammatory nociceptive, neurogenic, viscerogenic, that is internal organ related pain, central in nature, autonomic in nature, or even affective? For a more extensive discussion of the various types of pain, refer to the text and other video lectures that we've highlighted about history taking and pain mechanisms. Next, we need to determine the tissues, structures, and systems associated with the condition. Usually, the easiest way to guess what structure is involved is locating where the patient's bodily area of complaint is. In our case study, the patient is experiencing pain in the right hip and groin region. So our easiest guess is that there is something wrong with structures within that region. And based on your anatomical knowledge, what are these structures within that region? Some structures that quickly come to mind are the hip joint, the ligaments surrounding the hip joint, proximal tendons of the rectus femoris and sartorius muscles. The femoral artery, vein, and nerve also run somewhere in the region. From a superficial skin innervation point of view, this region is innervated by the ilioinguinal and genitofemoral nerve, which receives contributions from the L1 and L2 nerve roots. Before we proceed, we need to be careful sometimes that referred pain or symptoms can occur that may throw us off on the correct structures. To prevent being thrown off course, we need to keep the bigger picture of the patient's presentation or symptoms in mind. Are there any complaints that are located more proximally that may be linked to the more distal area of complaint? For example, the superficial cutaneous innervation of the area for this patient is L1 to L2. Are there any other complaints that the patient has mentioned that is related to L1 and L2? For example, a stiff or pain in the lumbar region. The innervation to the muscles, ligaments, and joints can also be taken into consideration for the potential of referred symptoms. The anterior aspect of the hip joint ligaments and the proximal aspects of the rectus femoris and sartorius muscles are innervated by the femoral and obturator nerves. Both have nerve roots of L2 to L4. So are there any patient complaints in the L2 to L4 back region? Are there complaints in the back region and the back pain is then related to the hip pain, for example? The pain in the back can, if present, increase up to a certain point, which is then followed by the hip pain. If this occurs, then there may be a possibility of pain referral. We should also bear in mind that sometimes viscera can contribute to pain referral. In this case, there is a possibility that the pain may be referred from the ureter or the kidney. However, looking again, this is unlikely given that there are no other complaints from the patient, such as pain during urination, an urge to pass urine, or running a fever, which suggests an infection somewhere. So the picture doesn't fit, and we can likely rule out visceral related pain. Another quick way of determining the structure involved in the condition is the potential mechanism of injury. Sometimes the patient can clearly indicate a specific time and incident when the condition started. For example, an inversion of the ankle due to a slip on an unstable surface, and this may indicate a sprain and associated injuries. A sudden and large physical force can be the injury mechanism, which can be the cause for fractures, muscle contusions, muscle and ligament tears, just to name a few. Most of the time, the symptom may have come on gradually, and this may indicate a more overuse-related injury such as tendinopathy, nerve compression syndromes, and stress fractures, etc. Each has their own type of symptom presentation, and you can be more certain of the structure by matching the pattern of symptom presentation. Usually, when we're looking at the condition, clinicians often determine the stage and stability of the condition. For stage, a simple way of classifying that this is how long the patient had this condition since its onset. Anything that is less than 3 weeks is considered acute. For conditions that has been going on for between 3 weeks to 3 months is considered subacute, and conditions lasting 3 months or more is considered to be chronic. There are also 2 other possible scenarios which overlays on the picture of the chronic condition. The first one is acute on chronic, and the patient has an underlying chronic condition. However, he or she has recently done something to aggravate it, which explains the reasons the patient is visiting you. The other scenario is the subacute on chronic picture. Although the patient has had an aggravation, but they have left it for much longer to see you, say between 3 weeks to 3 months. For these 2 scenarios of acute and subacute on chronic, you may be managing the acute or subacute onset. However, you may also need to start thinking about prevention of future aggravations of the chronic condition, and maybe also do longer-term planning for the management of the chronic condition as well. For stability, what we're thinking about is the progression of the patient's symptoms over time. There are a few scenarios which may contribute to our understanding and preliminary diagnosis of the patient's condition. These are: the patient's condition is improving, the patient's condition is worsening, the patient's condition is not changing, and the patient's condition is waxing and waning. That is, the patient's condition is fluctuating between better and worse. One other important category of information you wish to consider is the conditions warranting special caution or action. I'm referring to the red flags and yellow flags here. For those of you who may be unaware of what red flags are, Red flags are clinical findings that increase the level of suspicion that there is serious medical conditions presenting as common, non-serious musculoskeletal conditions. For example, people with certain types of undiagnosed cancer may have symptoms that may masquerade as musculoskeletal pain and symptoms. It is therefore important to spot these patients and refer them on to the appropriate specialist for timely and relevant treatment. You'll learn about these red flags during the course of the MSK modules. The other category of information that is also quite important are called the yellow flags. Yellow flags refer to the psychosocial factors that can negatively influence a patient's pain experience, recovery, and return to activity. Some examples of yellow flags that we look out for are unhelpful beliefs about their pain, anxieties about their pain, and the stress or distress about their function and work, catastrophizing about their condition, and passive coping strategies for their condition. You'll learn more about yellow flags during the course of the MSK modules. As you can see, determining the nature of the condition requires a lot more information to be considered. Let's try to come up with a working hypothesis of what our patient's condition may be based on some of the information categories we've just looked over. In terms of the structure that may be involved, what are some of the structures within the area that the patient is experiencing? In my mind, the first thought is that the pain is isolated to the hip region. So it can be the hip joint or any of the structures surrounding it. In the history taking, there is no information that suggests that it is a referred pain, as the patient has no proximal pain or any other symptoms that may suggest other tissues or organ referring the symptoms on. The next standout sign is the stiffness and pain that the patient complains of when waking up and after resting. This is a common symptom experienced by people with hip osteoarthritis. So because of this, we may have our first hypotheses of what the condition the patient experiencing may be. At this point, at the back of my mind, I'm already starting to plan some physical examination that either supports or refutes my osteoarthritis hypothesis. This may be range of motion tests for passive hip internal rotation and flexion, as these are the two most affected hip movements in osteoarthritis. I may also consider performing a hip quadrant test in order to stress the hip joint. I may also consider either asking additional questions if the patient is able to perform a squat or add this to my list of physical examination tasks. In the patient information, there is no history of trauma, so we can potentially rule out any trauma-related injuries. There is another important information that may add on to my initial preliminary diagnosis of hip osteoarthritis. The important information is the patient's pain progressively gets worse throughout the day, especially with weight-bearing activities. This is in addition to the age of the patient being above 50 years old, which is a predisposing criteria for osteoarthritis. It is also possible that the worsening pain at night may suggest osteoarthritis. Some of you are aware of the red flags, may ask me, but does this night pain suggest that's experienced by the patient is suggestive of a red flag for cancer? Maybe, but unlikely. The reason being that the night pain experienced by people with undiagnosed cancer can be unrelenting and not relieved by over-the-counter medications. On its own, night pain isn't a sufficient red flag, and this may have to be accompanied by fatigue and also unexplained weight loss for it to be considered significant as a red flag for potential cancer. The next question to ask is, are there any potential structures that may be the cause of the pain? We've identified that the rectus femoris and sartorius is in the region, so it may be something we need to rule out through our physical examination. We've also mentioned that the femoral blood vessels and nerve, a quick check of the circulation of the lower limb, and also any sensory changes in the affected lower limb may also be useful. But at this point, our major suspicion is hip osteoarthritis, and we can use that to guide the planning of our physical examination. It is also important to note that the above simplified clinical reasoning is my own, and another clinician may have a slightly different thought process, and this may or may not lead us to come to the same nature of the condition and preliminary diagnosis. To recap, in this video, we've looked specifically at the nature component of the SIN model. We've also mentioned that this is a useful model for helping extract the relevant information from our history taking and to plan ahead for our physical examination and for forming our preliminary diagnoses. In relation to the nature component, we have looked at some information categories that may be relevant for our case study of the patient with the hip pain. We looked at the information categories of pain type, bodily tissues, structures and systems, referred pain, specific anatomical injury types, stage and stability of the condition, and the red flags and yellow flags. In our next video, we'll be trying to integrate the analysis of our SIN components into the planning of our physical examination in order to test our preliminary diagnosis. So great! I'll see you at our next video then.